Perfect. And this week we're going to be kind of leaning into what we call our live well sessions. How do we adjust and accommodate for the changes that are happening within our relationships, within our homes, within the structure of our families? And this week we're having a conversation that's really kind of frank about some really common aspects of MCI denial, what denial is. And, you know, we have Debbie Arnold here who meets with members and care partners privately and in group settings to support really creative management of various challenges of living with MCI. She provides everything from education to counseling sessions to assistance connecting with other additional resources. And I know at CEP, what we're really interested in are skills. So Debbie's going to give us some skills to work with today. So I'm going to go ahead and pass it over to you, Debbie, just for a little brief introduction of yourself, where this conversation came from, why it's important to have, and why it's on the table today here at CEP Live.
Sure. Thanks, Megan. So the idea for this topic actually was born from our patient family advisory board and a conversation that they were having about how they remember at the year of programming, at the start of their year, there was just so much to adjust to at the Cognitive Empowerment Program, and all of these jargony initials of how we call Cognitive Empowerment Program CEP, and we all call Mild Cognitive Impairment MCI, and the sessions, the educational sessions near the beginning were like a fire hose of information. They were busy meeting one another and making sure they were in the right room. And it was really hard to absorb some of the knowledge that we were trying to pass on. And one of the earliest sessions is really a discussion about adjusting to the diagnosis and this process of denial, acceptance, and all that stuff in between. So that's how this topic, kind of the spark for this got going. And I myself have been a social worker for a very long time, over 25 years, in a variety of settings. But for the last 10 or 15 years, I've really been devoted entirely to adults with age-related issues of one kind and another, and cognitive decline of one kind and another, age-related, and when it happens a little earlier, and how that rocks a family's world. So I'm very interested in just really kind of putting cards on the table and talking about the things that are hard to talk about. So that being said, I wanted to have a frank conversation with y'all. And it's a conversation, except that I'm talking into the ether, and I hope you're nodding along with me. So, we turn to Calvin and Hobbes for wisdom. That's our great academic resource here at Emory, but it's not denial. I'm just very selective about the reality I accept. So, humor is our coping strategy of choice. But whenever we are having a conversation about something, it's good to agree on terms. So we're going to talk about what denial is, but equally important, what it is not. We'll discuss how and where denial may show up and why denial matters. It's really when denial matters. Sometimes denial's there, but it's no big deal. Sometimes denial matters quite a bit. And I've put together some tips for care partners when this common uninvited guest shows up. So, what exactly is denial? Denial is a defense mechanism. And I have a typo there, but that's okay. It's used to cope with a difficult reality and protect our ego. It is a normal thing, a normal human response. We all have a sense of ourselves or an ego that's honestly pretty fragile. And we tend not to appreciate any information that threatens our idea of ourselves as strong and capable and independent. So, a diagnosis of MCI kind of really kicks us in the teeth in that way. And denial shows up whenever our sense of ourselves is a bit threatened. And denial looks like the inability to see a truth or reality of something unpleasant. It really is not only something unpleasant. Anything big, any giant piece of news, good or bad, the first response tends to be, no way. That can't be, I won the Powerball. How can that be so? I can't conceive of this. It's so, I can't wrap my head around it. But it is a normal and a common human response. So even with a supposedly healthy brain, we can't always make sense of big news. The other way of thinking of denial, and I think it probably is familiar to people in context of Elizabeth Kubler-Ross's work on the stages of grief. And we can think of denial as sort of a way station along the way of accepting a diagnosis, because there is a grief process, right? MCI honestly does involve some losses for most people. They may be mild, because by definition, mild cognitive impairment means folks are generally more themselves than they are changed. They're more independent than they are needing assistance, but there is some loss that goes with it. There are some things I don't do quite as well as I used to, or I'm questioning myself in that way. Not everyone will experience all of these stages of grief, and they're not always linear. They look so neat and tidy here with the little arrows in between them. And if only we could check off denial, move on to anger, check that off, and it be a straight path the way it appears. But the truth is, it's a very circuitous route of doubling back and jumping ahead and not always knowing exactly where you are in this process. And kind of like a tossed salad where everything is touching everything else and kind of all has dressing all over it. It's much more like that in reality. The other thing is, denial is not just that river in Egypt, and I never get tired of that joke. Again, we use humor a lot around CEP. Denial is also not just reserved for the individual with a diagnosis, also known as the identified patient. Gotta have my air quotes. And while it is very, very common, denial is not a universal reaction. Some people are aware that there have been some changes. They don't exactly know what's going on, but getting a diagnosis is somewhat of a relief that their fears are validated and there's a name for this and a program with others who are experiencing something similar. So there's not always this denial. And although it's important and it is common, it's not always a thing that people struggle with. It also can be a stage, but it's not, like I said, it's more like a tossed salad. It's not a one and done kind of, you check it off and you're good to go. Denial is related to resistance, but they're not exactly the same. Resistance is more, it tends to be an acknowledgement of the facts of the situation, but there's some pushback about either how to interpret the facts or what to do about the facts. We often hear, thank you, nice social worker lady, for those helpful resources in the community, that website or that phone number. I will keep that in a safe place, but I don't need it now. And if you think I maybe need this kind of thing, but no, I don't really need that. I may have these limitations, but I disagree that that we need to do something about it, or I disagree about doing this. Resistance might take the form of not taking my medicine, or not agreeing to certain limitations on my driving. The other thing denial is not exactly the same as is this very long word at the bottom of the page that I'm going to mangle. I think it's pronounced anosognosia. So anosognosia gets its own slide. Sometimes it's not exactly denial. For some people, the changes in their brain actually make it difficult to recognize their own impairment. And that is what's going on with anosognosia. One of our participants explained the experience of when the evening news comes on, it feels like I have seen this before. This is very familiar. I've watched this episode. I've seen that video that they're going to the tape. I've heard this story before, even though it is a live feed and he knows that it is not something that has been shown before, and he couldn't possibly have really seen it before, but it feels that way. So that's one form of that. I hope that that's clear. The way I tend to explain it is, if I've recently enjoyed a big slice of pizza and I have a little sauce on my face, I might have a sort of a feeling on my skin and go look in the mirror, or go at it with a napkin, but I might not feel it at all. And I might need, someone that cares about me and understands that I'm going to be presenting on Zoom to a fair number of people to say, hey, you got a little something right there. You might want to wipe that off. I can't see it. I'm reliant on someone else or to go look in a mirror, but I'm not able to know that it's there. And I have to try to be open to the feedback of people who care about me. So that's that's where this comes in as a really important feature related to denial, is that we really, in our cognitive empowerment program, we're really trying to cultivate an attitude to being open to the observations that other people make. And we're working with care partners to really come from a place of compassion so that we're not blaming and we're not engaging in a power struggle, but we're validating. I know that you don't realize that this is going on, but in my perception is this. So that can be really important. And sometimes it's hard to tell whether the person's lack of insight is disease related, or due to denial, or it's something else. And often we do need to consult the provider, the neurologist, to help tease out some of that. So when and how denial show up, it can be really difficult to tease out. I have been told I have a relatively stubborn personality type. I'm sure that is hard to believe, but a lot of us do. And if you have a history of being somewhat resistant to hearing other people's opinions when they differ from your own, it doesn't get any easier when we start to have cognitive decline. Often denial will show up most in task or role specific ways. For example, I'm the one that pays the bills. I'm the one that has always paid the bills, and I'm not interested in, revisiting that. I don't want help paying the bills. I'm doing a fine job paying the bills, so I'm sort of digging in. Driving is another one. I might not dispute the fact that I have this diagnosis, but I think I'm a fine driver. I don't experience any changes in my driving, and I don't really want to hear feedback about it. Or if your role is to be more of the cook in your family, it might be a role like I'm the one that fixes the pies at Thanksgiving. That's my thing. Don't take that thing away from me. I'm perfectly capable. And not really recognizing how many skills go into something like making a complex recipe for a large number of people. Continuing to appear fine or passing for nothing has changed takes an enormous amount of energy. And increasingly, a person with cognitive impairment will need all of that energy to cope with other things effectively. For example, I bump into someone I haven't seen for a while, and I'm so busy being concerned about whether they're noticing changes that I'm finding it much harder to recall their name. And cognitive acuity is a moving target because MCI is mild by definition. Often the person feels like their old self and may not notice a big change in themselves. So moving along. For some reason, I am having trouble. There we go. Okay. Sorry about that. For a moment, I had difficulty advancing. Another related topic, a related topic that I think is worth mentioning here is that one of the things that makes it hard to acknowledge when there are struggles around certain things because of MCI is that the person with the diagnosis and the care partners and people who care about them all come to this situation with a lot of ideas about what cognitive problems and dementia diseases are like. And we get these impressions from movie and TV and books and our friends and coworkers who may have had a family member who had a dementia. And we've heard, these other war stories, so to speak. And that can color our experience so that it might actually prevent someone from seeking treatment or seeking a diagnosis early if they suspect they're having an issue, because we have this idea that you're either fine or you are completely out to lunch based on representations in TV and movies, and because our friends and our coworkers tend not to really share what's going on with family members until it's very severe and very stressful. So we do talk in CEP, we have one entire session devoted to how do we become more aware and combat stigma, and do so kind of system wide. But I borrowed this slide because I think it does impact the process of managing denial and acceptance. So I just thought that would be helpful to talk about. And it can delay or prevent someone from living their best life, living their fullest life with a mild cognitive impairment, from participating in clinical trials, and for really participating in important conversations about the future. So why does denial matter? Does it always matter? We don't always have to have an argument if someone says, I've seen this movie before and it just came out and you couldn't have seen it before. Big deal. It's not, it's not really a huge issue. Denial is problematic only if or when it delays treatment or support. The person is refusing services that could really be of benefit. Sorry, my things are advancing. Certainly, if safety issues arise, when there are concerns about, there are concerns about medication management, about firearms in the home, about driving, about cooking unsupervised. The kitchen is full of things that are sharp or hot, so safety issues do arise. And denial matters because family conflicts develop, especially when we consider that the person with an MCI diagnosis is not the only person that may experience denial. Many, if not most, families are sort of spread across the country now. And so if my sister in Maryland and my brother in California are not spending quite as much time with my parent. um, for them, things are fine. And especially if the parent tells them everything is going great, then I may be labeled, the chicken little whose head is on fire, the sky is falling kind of person, because they're not seeing what I'm seeing. And the parent is, denying that there are any issues. So that really is a recipe for family drama. Um, and finally, as I said, um, a lot of times this early diagnosis of mild cognitive impairment um, provides a window of opportunity that um, the person can participate in very important decisions and conversations. And that window of opportunity will narrow as time goes forward, just with age, but certainly if the dementia is going to progress. And honestly, we all need to have uh, advanced directives, which is exactly what it sounds like. It's directions that I provide in advance, even if I'm just a passenger in a vehicle in the traffic in Atlanta. I have to have written down somewhere what sort of medical treatment I believe in and I want to sustain my life, what quality of life means to me. Those are conversations that we just need to have with the people who care about us, because otherwise they're left scratching their heads. So this is just sort of a list of some tips, and y'all may have others, and I'm eager to hear other ideas for tips for care partners in managing denial. And the first one is breathe deep and choose your battles with compassion. I had a teacher in graduate school who said, manage your inner noise. So all that means try and be less reactive. Try and insert a beat between observing or hearing something in the person and making a decision about how you manage it. Does something need to be said right then? Should you think about it a little bit and then say something? Or maybe nothing needs to be said right then. Certainly, safety concerns should be reported promptly to the patient's neurologist, their nurse practitioner, or their cognitive neurology social worker. Ashley Varner and Alice Cooper are fantastic social workers, and they're super available to the families. Keeping in mind that denial, even anosognosia, often goes with this territory. So it's super important to emphasize that you are coming from love and caring. Validate the person's perspective. It's their truth. Even if you know they couldn't have seen this movie before, it really is true for them. So validating their thoughts on what's real, and then gently asking them to consider your perspective. The gently part is important because nobody ever came out of denial as a result of somebody arguing with them aggressively enough. Confrontation tends to increase resistance, and when we pull somebody from denial into wake up and smell the coffee, we risk really pulling them into a depression. Lastly, and most important, nurture the connection. As a care partner, you are like a player and a coach. You are a team with this person. It's the disease process, it's the cognitive impairment, not the identified patient, the loved one, who is your opponent. You guys are a team over here, and cognitive impairment is over here, the mutual enemy. So I feel like that is probably the key to hold in mind and to make all decisions from. Known you for many years. Oh, you're fine. I've known you for years. You're the same as you've always been. Um, and so what the process really does look like is asking your primary care doctor to do some short assessments in the office. They can do something called the Montreal Cognitive Assessment, which doesn't take any special training, and it's just a battery of 30 questions. And they're tasks like listen to this paragraph and then answer 2 questions about it, or say these numbers forward and then say them backwards, things like that. So that is, a pretty simple one that that doctors can do in the office. And also you can ask for a referral for cognitive neurology. And increasingly, Emory is expanding our training of primary care doctors, especially in the more rural areas of Georgia. And there's a great effort called the Georgia Memory Net, which is taking off to help support these physicians in the field to understand more about the process of diagnosis and which patients need to be referred to a neurologist. And then the neurologists are able to review records remotely, whether they be, these pen and paper assessments, or even things like a CT scan. They can review those things and really put together a picture of what might be going on with the person.
So I love that. Trust your gut, trust what you know about your brain, trust what things were a year ago, versus where they are now. Ask for those pen and paper tests, ask for the simple cognitive test. And I think that is so important for us to empower ourselves with all of those things. Somebody in the chat said, I'm finding this very helpful. My husband is in a skilled nursing facility, and I found myself in the middle of my spouse's way of seeing things and the way caregivers at the center view what is happening. We talk about this so much at CEP about putting ourselves in someone else's shoes. Especially as a caregiver, especially as the person who is in the shoes of being a care partner, that compassion that we're talking about, especially one of the tools that we can use practically to help us get ourselves out of denial sometimes can be putting ourselves in someone's shoes, understanding what your spouse sees, understanding what their daily struggles have been, how hard these changes must be for them, and giving ourselves that, moment to step back. So I love that. Thank you for the feedback from
Yeah,
that.
and the other thing I think I want to say, in case I didn't, is that people with a mild cognitive impairment often do very well with an individual therapist, as long as that therapist understands a little bit about mild cognitive impairment. And care partners often need some professional mental health support, whether individual or in a support group. It can be really painful if your spouse sort of takes it out on you, because you're the one who is observing the changes. You're the one that is calling to their attention that you don't feel safe in the passenger seat when they're driving. You may bear the brunt of a lot of um, this venting about, where denial and reality kind of intersect, and it's not pretty. Um, and particularly if what you're dealing with is more than a mild dementia, care partners get their feelings hurt left, right, and sideways. And you need to have the support to get up every day and, consider yourself a player and a coach and keep going.
Yeah, that's so good. And we've got some more questions that are
Mhm.
coming into the chat. Jim, who's one of our favorites at CEP, says, do you suggest having a person keep a written diary to be able to recognize issues about
Mm.
memory, since it comes on slowly for most and changes are not always that easy to recognize?
So I'm not sure that recognizing changes is the goal as much as it is to um, being able to negotiate with your care partner when concerns arise. So I think keeping a written diary or a journal is a really nice thing for a lot of people. That's a great way of coping with things that are challenging. And especially if you're a person with a short term memory deficit, of holding on to this light bulb moment that you may have about what's going on for you. Sure, having a journal or a diary is a great thing, but I don't I don't really want folks to feel like their main job is tracking the changes. You know what I'm saying? Like, it's more about working together with the people that care about you so that when you don't see things the same way, there's a conversation that isn't hurtful to either side and that you feel like you negotiate a way forward together.
That's really helpful, Debbie. Especially, I know sometimes we can get kind of stuck on small details as opposed to
Mhm.
backing up and taking sort of a view as a family or as a care partner. So
Mhm.
I love that. We also had some stuff come in from the chat from Flora, who feels like she's learned so much in Brain Talk Live and the CEP program. How do I help a family who needs this knowledge to support their relative? And I'm going to drop a few resources into the chat. I have dropped a link to the Georgia Memory Net. And this is a phenomenal resource that Debbie mentioned about connecting with providers and resources who are going to be really knowledgeable and skillful all across Georgia. If you're interested in participating in CEP program in person, I put some information about how to make an appointment with Emory Cognitive Neurology. Finding the right neurologist for you is so important. And if you're here in the Atlanta area, we do recommend the neurology clinic here. And if you're just interested in some of our resources like the videos and things on YouTube, if you want to dip your toe into the water of all the resources that we have through videos at CEP, I put a link to our YouTube channel as well. So feel free to connect with all of those resources. We did have some other questions come in. John asked, is it possible to determine if over medication is occurring? How, if you're not sure if you're having memory issues, because of over medication or things like that, we do always suggest go to your primary care provider, find the right primary care provider, monitor those things on a regular basis. And there are some medications out there. You can look through the history of our YouTube channel for information about medications for memory loss. There's a lot of new research. That's not necessarily
Mhm.
Debbie's specialization today, but do feel free to
Well, I
look
would
into
also, yeah,
those.
so I definitely would not hesitate to ask for, it's called medication reconciliation. where is one of my pills or maybe a combination of my pills um, resulting in brain fog or memory issues? Sure, that's a great question for the physician. I'm sorry, a phone is ringing here. And also your pharmacist is a great resource for that.
And what if we got a question in the chat? What if you know somebody? What if you're their barber or their stylist and you recognize an issue with your client? What is the right way to suggest something or to drop that? And is it appropriate? I love asking social workers these kind of questions because I feel like they are a good resource on some of these guidelines.
I think it really depends on what your relationship with the person is. If it's somebody that you feel like you have a good relationship with who is open to feedback, um, sure, it's something that you might be able to bring up to them, especially if you have a relationship with their adult children or their roommate, or if to check out your observations. I'm noticing some issues with this person, or there was some confusion about some appointments and I'm concerned. There was at one point there was a program where hairstylists were kind of recruited to intervene with when there were issues of domestic violence. And there was a training for hairstylists who might, really have an up close view of bruise, or, notice when there was a bump on somebody's head or something like that. And there was a training I noticed for folks to have those hard conversations. But I would definitely tread gently. Maybe the stylist could have a couple of books or magazines available that someone could pick up in their waiting area if they themselves were interested. But it is hard to know exactly what the right thing is to say to somebody, not knowing what the connection is.
Thank you, Debbie. And thank you so much to everybody who submitted questions, who tuned in and took some of these topics into consideration. These certainly are hard conversations to have, but we encourage you, especially as care partners and people experiencing MCI, to start to access some of these resources that we're offering. We dropped the news or the website for the Cognitive Empowerment Program and some of the resources we offer there into the chat. There's some links to being able to get our weekly emails about the announcements for CEP Live. So please do go and look into all of these resources. And Debbie, any last departing words as we think about denial and how to move through it and memory care? Any last words you'd like to share?
So to Flora, who said, how do I help a family who needs this knowledge to support their relative? Definitely the links that Megan shared, but also, be aware that this is where resistance sometimes shows itself, where you are saying, I've learned a lot about this, and I think it might apply to your loved one. Sometimes people are ready to hear that, and sometimes they're not quite ready. But I think that you are a wonderful friend for wanting them to. Information is power, and I feel like you're trying to empower them, and I applaud you for that.
Well, thank you, everybody. We've got a lot of comments about great presentation into the chat. Please tune in to see programming next week. We're going to be presenting with our nutritionist about the mind diet and some more lifestyle changes. After that, the following week, we'll have our cognitive team here. So we will see you same time, same place next week. Thank you, Debbie, so much. Vicki, oh, so good to hear you on today. Thank you to all the regulars, and we'll see you next week.